Hi, my name is Jackie. I'm a respiratory therapy student at Delta.
Hi, I'm Trent, and today we're going to talk about non-invasive positive pressure ventilation. Now, non-invasive positive pressure ventilation, or NPPV for short, has many different names. One of them is BiPAP, which is very popular from the company Respironics. Now, BiPAP, or non-invasive positive pressure ventilation, has two different levels of PPV. There is inspiratory positive airway pressure, or IPAP, and there's expiratory positive airway pressure, or EPAP. Now, IPAP is similar to pressure support in that it gives support to ventilation, and it also decreases the work of breathing and increases tidal volume. Now, EPAP, it's similar to CPAP or PEEP. It increases the oxygenation by increasing FRC, and it also increases the PaO2, and it enhances alveolar recruitment. Now, there are some indications for using BiPAP. One is an exacerbation of COPD or asthma, and also there's an indication of acute respiratory failure. Now, the most significant part about this is that with acute respiratory failure and using BiPAP, you can avoid intubation sometimes with that. And the nice thing about that, it reduces the amount of airway trauma. It also increases or reduces the amount of the hospital stay, as well as aspiration, reduces that. And also nosocomial pneumonia and patient discomfort. It decreases all of those things. Now, there is evidence established that NPPV can safely and successfully give you all of the ventilation that you need without patient discomfort until the respiratory failure that started is taken care of. NPPV facilitates weaning from invasive ventilation, in that whenever the person is a weaning process or taken off, sometimes their muscles are a little weak, and this gives them the needed support to increase the work of breathing and also increase the volumes.
Gives the muscles a chance to rest.
Now, there are some patients who have a DNI or a DNR status, and what this does, it allows them, they don't want all of the
rescue efforts,
thank you, done, but without the tube down their throat. They'll do everything but that. And with the non-invasive, there's no intubation involved, so this meets their needs and criteria. Now, a patient must be a spontaneous breathing patient, and also they must have a patent airway and be able to protect their airway.
Okay. So this is a Philips V60. So this is an advanced BiPAP. I like it. Sound is loud. Good starting settings for BiPAP are about 10/5. 10 being the IPAP, or the ventilatory support, and 5 for the EPAP, or the oxygenation status. That's about normal ventilation, like for a normal person. Oxygen is right now set at 21%. It can go all the way up to 100% on this machine. My eye time is set at 0.9 seconds, which is normal. In this model, I would go into menu and set up my mask and my exhalation port out. So I have to actually program which mask I'm using and which exhalation port I have. And on this screen, it gives you choices and shows you pictures. So I'm going to accept number 1 on this because that's the mask I'm using. And this is the port, the exhalation port I'm using. There's all different settings I can use, brightness, loudness, but I'm good. So I'm in BiPAP mode. If I wanted to change my settings for a patient that was still not oxygenating well, I did my EKG 30 minutes later, on my settings at 10/5, and we still had a high CO2 level. I did increase my IPAP. I'm going to go up to, say, 12/5, because I want to increase my minute ventilation. If I wanted to keep my minute ventilation the same, I would increase my IPAP and my EPAP by the same amount. So to keep my minute ventilation the same, and I wanted to increase it, I would go to 12/7. Let's do that. Alarm setting. My alarm setting should be set tight. Right now they're not. My minute ventilation should be set about 1.5 liters above what the patient's doing and 1.5 liters below what they're doing. I should make sure that all my connections are tight so that doesn't happen. My alarm settings want to be set tight. My minute ventilation, I want it to be about 1.5 liters above what the patient's actually getting and 1.5 liters below what the patient's getting. My iPad settings, I want about 3 above the iPad and 3 below the iPad, not the EPAP. EPAP is not the basis for the alarm settings. So my I'm set on 14, so I want it 17 and 11 for my inspiratory pressure and for my high and my low inspiratory pressures. Okay. This machine will actually show you whether you're getting a spontaneous inhalation or a mandatory inhalation, or if the patient's shorter or if the machine's shorter. Right now, up in the upper, in the upper left-hand corner of the screen, the light blue flash that you see is when the patient takes a spontaneous breath. So when Trent takes a breath, you see the light blue bar. Now if Trent stops breathing, it takes 20 seconds, or however long you set it to. Set to 20 seconds, and then it'll give a breath, and you'll see an orange bar in the corner of the screen, and it'll say time. That'll give an iPad breath. So it's just the pressure breath. I'm going to put this in standby.
Okay. Well, there are some exclusions for BiPAP. Respiratory arrest would be one, hemodynamic instability, excessive secretions. Also, if the patient has a problem with a brain injury, or some sort of face deformity or trauma to the face.
Because what I forgot to mention was you need a really good seal when you put this mask on a patient's face. So if they have a facial deformity, they're not going to get a good seal. There's not supposed to be a big leak, but you need to have a leak. So you need to have less, probably about 10 to 20 cc's of air leak when you have it. Try to have this on his face and he can do it.
Yeah, I had a good seal on it.
When you hold it to your own face, of course you're going to get a good seal.
Well, those are some of the indications for a patient needing invasive ventilation. Thank you.